Hello everyone and welcome to BAC Dental Channel. Today we're going to be doing a chapter review on chapter 11 of Dr. Proffit's book. This chapter talks about moderate non-skeletal problems in pre-adolescent children. So we're going to be taking a deeper dive into the subject. This PowerPoint I have highlighted what I think are the most important parts of the chapter, so it doesn't cover everything, but it will cover what I think is the most important points. So it's a summarized idea of this chapter 11. So let's get started. So we're going to talk about, I'm going to start off with orthodontic triage. We're going to be distinguishing moderate from complex treatment problems. So we ask ourselves the question, is it too early to start, or is limited orthodontic treatment needed? If so, when should it be done? And if a referral is needed? So step number one, so Dr. Profit breaks this down into multiple steps, and we're going to be talking about each of these steps. So steps number one, it's to determine if the problem is severe by doing a full face analysis. And we know that skeletal asymmetry is always considered severe. So this is something that you're going to be looking at your patient as soon as they enter the operatory. You're going to be looking at their face and doing an analysis even before they sit down, and you're taking a look at their teeth. So that's step number one. Step number two is the facial profile analysis. So what's important here, and what I want you to take note is that usually we can defer these types of treatments. So class 2 treatment, long face open bite problems, and short face problems, we can usually treat them a little later. Excessive protrusion and retrusion of incisors that require extraction can also be deferred. However, class 3 treatment, maxillary deficiencies should be addressed early. Now, step number three is dental development. So problems with dental development often require treatment right away. And these are, when you have a missing permanent tooth, and most likely this is most common in maxillary laterals or mandibular second premolars. We can treatment plan to decide whether to maintain or extract the primary tooth. So if posterior primary tooth is enclosed and there's no permanent successor, we can consider decoronation and replacement with implant later on. And then extracting this enclosed teeth allows permanent teeth to drift, which must be treated early. Another issue with dental development is when you have supernumerary teeth, and most of these early removals indicated. 90% of these supernumerary teeth are found in the anterior maxilla, in between the upper ones. And cleidocranial dysplasia, the syndrome, is usually associated with multiple supernumerary teeth as well. That's something to note for. So remember cleidocranial dysplasia associated with supernumerary teeth. Now we also have another problem, which is ectopic eruption and transposition, and early intervention may reduce the extent of malposition later on. So here you can stop and take a look. This is basically goes a little bit deeper of everything I just said. Like I said, everything that I'm saying is basically summarized. So this goes in a little bit deeper to explain a little bit more of those steps 1, 2, and 3 that we just spoke about in the orthodontic triage. Now continuing, we have step number 4 and step number 5. So step number 4 is space problems. So we usually use a space maintainer in mixed dentition for early loss of primary canine or molar. Space regaining simple appliance in mixed dentition is used if early loss has led to a deficiency of 3 millimeters or less. If severe crowding of 10 millimeters or more, you may require to do serial extraction. Now, step number 5 is other occlusal discrepancies, and these include a posterior crossbite. And if you do have a CR/CO shift, which is something that you should check when you have a posterior crossbite, it should be treated early. Now, anterior crossbite due to the lingual tipping of the upper incisors, we can use a removable appliance to tip these incisors labially. And when we have excessive overjet due to flared and spaced upper incisors, we can also use the removable appliance to tip these incisors lingually, if there is vertical clearance, of course. And anterior open bite, remember how we said it can be deferred. So anterior open bite should only be treated early if it's due to an oral habit. So if there is a tongue thrust or a thumb sucking problem, then this anterior open bite should be treated early. If not, then you can defer treatment. And then another note that Dr. Proffit mentions in his book is when we have traumatic displacement of teeth, if it's an open apex, then you can allow spontaneous eruption. So once again, you can go ahead and pause this slide, talking a little bit more into deeper detail about step number 4 and step number 5. Now, management of occlusal relationship problems, we're going to touch on that aspect now. So, in a posterior crossbite, we know that in the book it mentions 7.1% of US children aged 8 to 11 are affected. So, this is usually due to a narrowing of the maxillary arch and could be due to a prolonged sucking habit. It's very important for you to rule out whether this posterior crossbite is skeletal or dental. And as we stated earlier, early correction if there's a CRCO shift. Ideally, you want to treat this posterior crossbite before the mid-palatal suture bridging, so you can use expansion appliances. And 1 millimeter increase in the interpremolar width gives you about 0.7 millimeter increase in arch parameter. That's an important number there. So number one, what we're gonna do when we have a posterior crossbite is we're gonna try to equilibration to eliminate the mandibular shift. So occlusal interferences that are usually caused by the primary canines or primary molars could be causing this shift. So we're gonna try to eliminate those. Number two, we're gonna expand a constricted maxillary arch. So in Dr. Proffit's book, he mentions that the preferred appliance for a pre-adolescent child is a quad helix or a W arch. The best indication for quad helix is when you have a posterior crossbite and a sucking habit. So this quad helix will not only act as the expander, but it would also act as a tongue crib or as an appliance that will impede the patient from sucking their thumb. Since it's placed up high on the palate, the patient can no longer place their thumb in the palate and suck on it. So you achieve about 50% skeletal and 50% dental expansion with a quad helix, a W arch, or a jack screw device. So average palatal expansion is about 3.9, about 4 millimeters, so that's an important number. And average intermolar expansion is about 6.5 millimeters. So usually you expand 2 millimeters a month, and the rule of thumb is until the lingual cusp of the maxillary teeth occlude on the lingual inclines of the buccal cusp of the mandibular teeth. So usually you want to expand for about 2 to 3 months, so 2 to 3 months of active treatment, and then you want to have 3 months of retention for bone to fill in into the mid-palatal suture space. Now, number three, we have unilateral repositioning of teeth. So a W arch or a quad helix will always have some bilateral expansion no matter what. So an alternative when you need unilateral expansion or unilateral repositioning of teeth is using cross elastics, in this case 3/16 with 6 ounces. And if, let's say, the lower teeth are well positioned, what you can do is use a lower lingual holding arch or a lingual arch to stabilize the lower teeth and then only get the tipping or the repositioning on the upper. Now here are some pictures of what the quad helix and the W arch look like. So you can see that the quad helix has 4 helixes hence its name. And like we said, this will impede, if the patient has a thumb sucking habit, this will impede the patient from placing their thumb into the palate. So it will work great. Now, management of occlusal problems. So now we have the anterior crossbite. So what's the etiology? Well, it's usually due to a lingual eruption of the maxillary teeth or facially positioned mandibular teeth. The most common etiologic factor for non-skeletal anterior crossbite is the lack of space. So when you have a lack of space, you're usually going to have this lingual eruption of the maxillary teeth, and you're going to have the patient going into a crossbite. So correction is indicated in the mixed dentition because this anterior crossbite will limit jaw movements, and it can also cause gingival recession on the lower incisors. Think about the upper anterior teeth hitting the lingual of the lower anterior teeth, pushing it forward, causing this gingival recession. So the you can use a removable appliance with finger springs, like we have the picture here on the right, to tip these maxillary anterior teeth facially out of crossbite. And you will be activating about 1.5 to 2 millimeters, which will lead to 1 millimeter of tooth movement a month. An alternative is also using a lingual arch with solder finger springs. However, a patient that has not severe crowding, but that has crowding rotations and need bodily movement of these teeth, a more ideal solution would be a 2x4 appliance. Now, management of occlusal relationship problems continued with the anterior open bite. So We were just talked about the anterior crossbite. Now we're going to be talking about an anterior open bite. So how can we know that this anterior open bite is skeletal? Well, you're going to have an increased lower facial height with an extreme open bite. Now, an open bite in pre-adolescent child with a normal vertical facial proportion is most likely caused by a habit. So we want to stop this habit and we want to treat the habit early. As long as the habit stops before the eruption of the permanent incisors, most of the changes resolve spontaneously, except for a posterior crossbite. The simplest approach is an adult discussion, and if these don't work, then using a maxillary lingual arch with an anterior crib is the solution. Now, for a deep bite patient, so we just talked about the anterior open bite. Now we're talking about a deep bite patient. So treated early only if there's tissue damage. So only if those lower incisors are impinging on the palatal tissue, right about on the rugae. And for these patients, you can use a removable appliance with a bite plate that will allow the eruption of or an anterior bite plate that will allow the super eruption of the posterior teeth and open the bite. So the molars and premolars will get super erupted and it will open the patient's bite, relieving the deep bite. Now we have over retained primary teeth. So in Dr. Proffit's book and in a lot of other books, we know that permanent teeth should be replaced by, or the primary teeth should be replaced by the permanent teeth when about 3/4 of the root of the permanent teeth has formed. So if the primary teeth is retained beyond this point, usually an extraction is indicated to your pediatric dentist or whatnot to get the teeth out and allow passive eruption of the permanent tooth. So we also have ectopic eruption. So now we're going to go over the three most frequent deviant paths of eruption. So number one, we have lateral incisors. So when we have permanent lateral incisors erupting, it is common for resorptions of the primary canines. It's actually common to get some resorption of the primary canines. And if one or both are lost, this is just pretty much indicating a lack of space for all permanent teeth. So early loss of maxillary canines, it's not really indicated to do any treatment. It's fine. Now, early loss of mandibular canine, you can do a space analysis to determine the treatment. One of the solutions for an early loss of mandibular canine is doing a lower lingual holding arch to maintain the leeway space or the E space. And if there's early loss of just one primary canine, in Dr. Proffit's books, he says that there's no need to extract the contralateral primary canine because the prevalence of a clinically significant midline shift after the premature loss of one primary canine is not significant. So, in Dr. Proffit's book, he mentioned that early loss of one primary canine does not need to extract the contralateral primary canine. In these cases, you can consider a 2x4 or 2x6 appliance. Now, maxillary first molars. So when the maxillary first molars are erupting, there is a small amount of resorption that happens in the primary molar and or the E's. So we want to keep that and observe how much more resorption occurs. So if it persists for 6 months or resorption increases, then treatment is definitely indicated. You do not want an early loss of those E's. One solution for this is placing a brass wire or a steel clip separator between the contacts. Another solution would be elastomeric separators, but this is not entirely recommended because they can be easily dislodged apically and cause some gingival inflammation on the patient. Now, so we talked about ectopic eruption of lateral incisors of maxillary first molars, and now we're going to talk about maxillary canines, which is very, very common. So at 10 years of age, if the primary canine is not mobile, then there is, and it's not observable or palpable by the facial canine bulb, you can expect an ectopic eruption of the maxillary canine. So can lead to impaction of the canine or resorption of the permanent lateral incisors or central incisors root. So that's why if by 10 years of age you don't really see a mobile primary canine or you're not really noticing this facial canine bulge, then you really have to be careful because you want to take a panoramic X-ray to assess the location of this canine, make sure it's coming down and it's coming down in the right direction. So The reason for canines to have an ectopic eruption or to not be coming down its correct path can be related to having a small or a paglateral or having a missing maxillary lateral or missing secondary molars. So because these teeth are not present, sometimes these permanent canines don't have really a path and don't really have a track a path to follow for eruption. So they kind of just they get impacted or they erupt ectopically. So now in Dr. Proffit's book, we have a nice little diagram here for the successive rate of early deciduous canine extraction. So if the erupting permanent canine is mesially positioned, um, so if this permanent canine is mesially positioned, and we're gonna draw a line here by the maxillary lateral incisor, and if it's distal to that line, then you have 91% chance of bringing this canine in without needing to surgically expose. And if this maxillary canine is mesial to that line, so let's say if it's almost touching the root or by the root of the first central incisor, then that means that you only have a 64% chance of bringing this canine in without surgically exposing it. So as soon as you see, I think the primary goal that I want you to get out of this is if by 10 years old you don't see a canine bulge or you're not really seeing a mobile primary canine or a C, then you definitely want to take an X-ray, a panoramic X-ray, making sure getting the location of this permanent canine and acting promptly so you don't get something worse and you don't get any resorption of the lateral or the centrals and you don't get an impacted canine later on. So now let's talk a little bit about supernumerary teeth. So something important is you should know that the most common location for supernumerary teeth is in the anterior maxilla. And how would you determine which tooth should be kept? Either the supernumerary or not. So the tooth that should be retained is the one with the best size, color, morphology, and position and related to other teeth. So that's how you're going to decide whether to keep the supernumerary tooth or not. Now, delayed incisor eruption. So when we have an incisor that has failed to erupt more than a year past the normal eruption time, then you cannot delay treatment. A deeply positioned tooth should have an apically positioned flap and a bonded attachment with a metal chain for traction and to bring it down. Now, ankylosed primary teeth, I'm gonna go over a little bit faster on this so we can keep moving, but an ankylosed primary teeth with a permanent successor usually resorb with no problem. When 3/4 of the root of the permanent tooth is formed, the primary tooth should be mobile, and then you shouldn't expect any problem or anything like that. Now, an ankylosed primary tooth without permanent successors, in order to avoid long-term period problems, the ankylosed tooth should be carefully extracted before a large vertical defect or an occlusal discrepancy develops. So even if the ultimate plan is to replace this missing tooth, it is best to move teeth at least partially into this edentulous space to bring bone with it, and then reposition the tooth prior to the implant placement. So that's another important thing. In this case, space maintenance is contraindicated because you're going to be moving teeth into the edentulous space. Now, um, if in the other case, when you have an ankylosed primary tooth with a permanent successor and you're planning on extracting it, then maybe a lower lingual holding arch or some type of space maintainer should be used in order to prevent any tipping or any space closure and allowing this permanent tooth to erupt. But most of the times, this permanent tooth will erupt without any space maintenance, or it would just come out. Now, let's talk about the premature tooth loss when you have adequate space. So space maintenance is appropriate only when adequate space is available and when all uninterrupted teeth are present and at a normal stage of development. So if a permanent successor will erupt within 6 months, or if more than one half to two-thirds of its root has formed, a space maintainer is unnecessary because most likely this tooth will just erupt into space and there won't be any space problem or any space closure that you need to worry about. Now, space analysis. how do you quantify space problems? Well, we calculate space available and then we subtract the space required. So you can take a look here on the screen if you want to know how to calculate those, but basically you're calculating the arch parameter from the contact of the first molar to the contralateral first molar, and then you're adding up the mesodistal width of each erupted tooth and subtracting it from there. And then you can estimate the amount of space deficit that you have, and you can determine whether you need space maintenance or not. Now let's talk a little bit about the types of space maintainers. So we have abandoned loop appliance, we have the partial denture space maintainers, and we have the distal shoe space maintainer, and then we also have a lingual arch space maintainer. So starting out with the abandoned loop, this is generally used in mixed dentition to save the space of a single prematurely lost primary molar. And as you can see here on the pictures on the right, it consists of a band on either a primary or permanent molar and a wire loop to maintain space. Now, partial denture space maintainers. So this is most useful for bilateral posterior space maintenance when more than one tooth has been lost per segment and the permanent incisors have not been erupted. The distal shoe space maintainer is indicated when a primary second molar is lost before eruption of the permanent first molar, and is usually placed at or very soon after the extraction of the primary molar. And then we have our nice lower lingual holding arch, which is indicated for space maintenance when multiple primary posterior teeth are missing and permanent incisors have erupted. So this will prevent the anterior movement of the posterior teeth and the posterior movement of the anterior teeth. So this is what a lower lingual holding arch looks like. For the upper, we can use a lingual arch as well. However, there's some drawbacks. So for a conventional lingual arch on the upper, it's contraindicated for deep bites because we don't want those lower anterior teeth to be biting on it. Now, we can also use a Nance. However, you can get a little bit of tissue irritation with the Nance appliance. And we can also use the TPA. However, it's contraindicated when bilateral primary molars are lost. Permanent molars may tip mesially despite of the TPA. Now, space regaining from localized space loss. So localized space loss, 3 millimeters or less, there's a good prognosis to regain the space. So after early extraction or loss of primary molars or canines, drifting of permanent incisors or molars occur during the first 6 months. So repositioning the tooth to regain this space and reduce discrepancy to zero, you want to do that first and then place the space maintainer. So if the space loss is over 3 millimeters, then comprehensive treatment is usually required, and extraction with space closure is often a better choice. So here we have treatment of space problems in the maxilla. So moderate space loss, less than 3 millimeters of space, like we said, there's a good prognosis of regaining the space. It is easier to regain the space in the maxilla than in the mandible, and some of the options include a removable appliance with finger springs, as we can see here with the image on the left, to distalize that molar from the space loss from the mesial drifting. We can use a fixed appliance on the right with a coil spring to distalize on a segmental wire, and that open coil spring will, distalize that molar, create some space for the erupting tooth. And then it's also using a palatal anchorage, so a Nance banded to the force, and that will prevent, even though there will be some anterior movement from those force, because the rugae and the palate is soft, so you do expect a little bit of anchorage loss there. You're mostly going to be getting some distalizing movement on the molar, so it's going to get distalizing movement and a little bit of a distal rotation as well, which will open up space for that erupting tooth. Now, treatment of space problems in the mandible. So some treatments include the lingual arch for unilateral space loss, for anchorage, and for moderate arch expansion. You can adjust the loops for that. And you can also use a lip bumper, usually used or indicated for bilateral space loss to increase the arch length. It will distalize and tip those molars backwards a little bit, and you'll get some minor space regaining and moderate arch expansion. So here on the left, on the bottom left, you can see the lower lingual holding arch, and on the right, you see the lip bumper. Now here's a flowchart that you can take a look and stop if you like, and it can use to aid in the decision whether space maintenance in the primary mixed dentition is needed. And so now we're going to talk a little bit about mild to moderate crowding of incisors when there's adequate space. So up to 2 millimeters of incisor crowding may spontaneously resolve without treatment when transitioning from primary to mixed dentition. And you do not need to worry about that. What you can do is you can consider some IPR on the primary canine or molars to give you that little bit of space in order for those anterior teeth to align on their own. For spaced and flared maxillary incisors, we know that excessive proclination and spacing are seen in mixed dentition due to prolonged thumb sucking. So we want to eliminate the habit before that. What you can use in order to fix these flared and spaced incisors is a Holly type appliance. So you can use it. You can use this Holly type appliance by activating the labial bowl in the front and bring these maxillary incisors back if there is vertical clearance, of course. So if there is a deep overbite, vertical issues must be addressed before retraction of upper incisors, and a complex treatment is needed. And lastly, we're going to talk a little bit about maxillary midline diastema. So usually this is referred to the ugly duckling stage. And commonly, a small maxillary midline diastema presents in many children, but it's not necessarily an indication for ortho treatment. So this space will usually close on its own with the eruption of the permanent canines, which will push everything more mesially and close this gap. However, a small diastema of about 2 millimeters or less can be treated early by a removable appliance with clasps, finger springs, or an anterior bowl, as you can see here on these pictures on the bottom. Now, when a larger diastema, let's say of about 2 millimeters, is present, a midline supernumerary tooth, intrabony lesion, or missing permanent laterals must be suspected. And for low-hanging frenum, you usually want to determine whether this frenum will cause some problems with retention. So some frenectomy might be recommended in order to aid with retention and aid in space closure. However, early frenectomy, it's good to note that early frenectomy is usually avoided, and you should try to close the space first and then have the frenectomy done. So this is it for what I have. Thank you very much for tuning in. If you have any questions, you can comment in this comment in the section below, in the comment section below, and I'll make sure to answer everything. I will be continuing doing these chapter reviews with other chapters that I think are very relevant and important for you to know. But once again, thank you very much for tuning in. And I know this was a long video. Hopefully I can start making them shorter. And I'll see you next time.